So, dear Chairman, dear colleagues, thank you very much for the invitation. It's a great pleasure to present MRI here. We had great talks about nuclear and CT, and I hope I can show you the beauty of my field. So the learning objectives I got from the organizers was one, to show you how the protocol in MRI works, the setup, interpretation of images, then how to diagnose and how we get prognostic information from MRI. And the last was how we can use this in microvascular disease. So these are many topics. I hope I can put them all together in a sufficient way for you. So the background, CMR is increasingly used to diagnose coronary artery disease. And since last year, we have a class 1 indication from the ESC, which makes it much more easier to compete with the other techniques we have around. So we can detect CAD, we can see actually if the stenosis is flow limiting, and we can give the patient prognostic data. So we can do this once by direct visualization of the coronary arteries. This is nice, takes a little bit longer, but it's actually, I think, a cool thing, but CT is still much better in this part. The other way is to detect ischemia. And here we have two ways of detecting ischemia. One is by wall motion analysis or by perfusion measurements. So how does the protocol look like for MRI? It takes around 30 minutes if you have a good team. It can take up to 2 hours if you have a bad team. So I would say maybe the truth is 45. So you acquire standard survey images to plan, then you go to function. You can switch, then you go to perfusion, stress, then you go to rest perfusion. At the end, the contrast is in the patient. You just go over and acquire viability, light enhancement images. If you want to speed up, you can switch. You can do the stress after the survey scan, and during the pause between stress and rest, you can acquire the function if you want. You always have a little bit of time before late enhancement. If you want, you can put some flow measurements in the aorta, in the valves, wherever you want, or you have a question. So you can also evaluate the valves in the patient. Then, if you have time, you can also acquire coronaries if you want. This is quite nice. It takes 5 minutes, and you have this information. If you need this, I'm not sure, but you can. So what is important when you do stress imaging, you have to monitor the patient, and you have to rule some safety aspects. So you have to monitor heart rhythm, blood pressure, and respiration. This is mandatory in all stress exams. Then you need a physician and a technician who's trained in reanimation. And what is really important, you have to train to evacuate the patient from the scanner. Because when the anesthesiologists come to rescue your patient, they run in with all these gadgets. And before they are in the scanner, you have to have the patient out. So please train this. This is very important. So everyone, I guess, knows the Ischemic Cascade. It's like this. It starts with the perfusion defect. That's why we like to look at perfusion. Systolic dysfunction comes later. So you have to stress the patient more. Then ECG changes are quite late. Chest pain is the last you have on the Ischemic Cascade. And when you are too late, you have the infarction. So we have to have a method to find the patient fast to get him out of this infarction problem. So how can we do this? In the scanner, there's no physical exercise possible. So we have adenosine. We learned we can use regadenoson or dobutamine. So we have these things. So just briefly, we already had this in the previous talk. So we use adenosine at about 140 mics for about 3 minutes. You can consider to going up to 210 if you are not sure that the patient reacts on this. This is not possible in all countries, and not everyone feels good with this, but you can do this. The half-life is very short. It's just 4 to 10 seconds, so you're very safe with this. Nothing can actually happen. But you can switch. If you're still afraid of asthma or cold, you can have regadenoson. It's also easy. You just give a bolus. you wait 10 seconds and you can image. But half-life is long. They write 4 to 10 minutes, but sometimes the patients even feel this 10 minutes, 20 minutes, even to an hour later. So there are some antidotes. Stop this infusion. Give aminophylline. And very important, you have to instruct the patient before he comes to your shoot. So no caffeine and no aminophylline and nitrates 24 hours before. Jumbutamine is known in stress echo, be like this, to use also for MRI. You have a standard protocol of 5, 10, 20, 40 mics to go up to the heart rate you want and to image at that time. Antidote is obviously a beta blocker, so you stop the patient with this. Nitrates to take away his pain. And important, you have to tell the patient to stop beta blockers and nitrates 24 hours before. Otherwise, it's really difficult to stress this patient. And the most important thing about this dobutamine, to get target heart rate. If you don't get it, this whole test is worthless. So how does this work? So we take a gadolinium-based contrast agent, we inject this over the vein, it travels through the body, and we get a MR signal. That's quite easy, and it's easy to do. But MRI has some requirements, and you need high temporal resolution, so you have to acquire every second or every heartbeat. You need an ultra-fast readout of 100 to 125 milliseconds, or even shorter if it's possible. You have to acquire parallel imaging to get this. You want to have spatial resolution as high. Best is below 3 millimeters, and you have a slice thickness of 8 millimeters. And you want to cover as much as possible. Nuclear techniques have the advantage that they cover the whole heart. And that's what we always hear. We are not covering the heart, so we don't know actually what's going on. But I think 3 slices is sufficient. Then you acquire 50 heartbeats. So you follow your bolus over 50 heartbeats. We call this dynamics. Usually we use a T1-weighted sequence. Mainly, it's a balanced SSFP sequence. It has the highest peak enhanced. Its superior image quality was shown in many studies compared to T1 gradient or EPI sequences. You can use fancy sequences like the KT Sense, KT PCA, whatever they call it, KT Grappa, to do very high resolution. And the main dose of contrast agent you use for the image is 0.5, 0.05, or 0.1. It depends what you like. So how does this work? You have a RR interval. You apply a pre-pulse to null the myocardium. Then you have a readout time of your slice. Mainly it's 3 slices from apex mid to the basal one, as you can see. You try to do this in one heart RR interval. It goes, but the most sequences you can go up to heart rates of 120, and it looks quite nice. How do you time actually your thing? So it's not so easy to get to train the technicians to get the optimal point of the breath hold. So it's like we do is we start the scan, so we hear the scan. We can check for triggering. Then we give the patient the first breath hold command. Then we inject the contrast agent, and when we see on the real-time images that the contrast agent arrives at the right ventricle, we give the second breath hold command. So the first pass, the heart is not moving, and you have perfect images. After that, the first part is gone. You give the patient, again, he's breathing, so free breathing, and you can see the images. So this looks quite nice. There are 3 ways of analyzing MRI images. And most of them and most of the studies are based on visual assessment. Excuse me. So we have to follow, actually, the bolus, and we have to see what's going on. And there are 3 things you have to be aware when you watch this. So you have to first see the signal intensity pattern and location. Where does this perfusion defect start? Usually it starts from the subendocardium, with or if it's completely transmural, you have a transmural. You have a dynamic filling, so it means this defect is there, but for a certain time, and then it fills from the epicardium. So you have to know this. If you have a defect there before the contrast agent arrives at the LV, this is surely a dark rim artifact, but you have to consider this. And you always have to look at the stress, the rest, and the late enhancement images at the same time to compare if there is a scar, if there is a, like the nuclear cell match or no match. This is very important. There are several ways. So I said mainly we use visual assessment. There are ways to do this semi-quantitatively. And this is a study from 2003 from Imagenologia from Berlin. He did this semi-quantitative, and the best way to do this is using upslopes. And in this study, you see that in the upper part, you see that if there is a segment of healthy myocardium, the upslope changes between rest and stress. So we have a normal perfusion reserve. And if you have an ischemic part, your If there is ischemia, there is no difference between rest and stress flow, so you can nicely detect ischemia. This is area under the curve, a rock analysis, and you can see that you use the perfusion reserve corrected for the LV input function, you get the highest diagnostic accuracy. If you don't correct for the LV input function, it is lower. If you only use the upslopes, you have the lowest diagnostic accuracy in this thing. As we know, PET is fantastic. They can quantify myocardial blood flow. We can do this too in MRI. It's not as robust and it's not as used as in PET, but you can do this. This is a nice study just published more or less 1 year ago, where they compared pixel-wise analysis of rest and stress, and you can nicely see that if there's a perfusion defect, there's lower tissue perfusion, and this correlates well with microspheres. So the correlation was quite high. So this is a method you can have, but it's not something you do on daily practice. It's more for research. So as I said, you have to really carefully look on the images when you interpret. And here is a reason they always talk about this dark rim artifact. You see this dark rim, and we always have this discussion with people coming to our lab. Is this a perfusion defect or is this a dark rim effect? It's not so easy, but there are some ways of dealing with this artifact. And one way is of increasing spatial resolution. And on the left side, you see a standard perfusion of 2.5 millimeter in plane, and on the right, you have a high resolution. And you see the dark rim artifact decreases. So it is as thick, mainly as 1 pixel in the in-plane resolution. So you know that it is usually in the phase and cold direction, and from this you can distinguish if this is a perfusion defect. And mainly is really black, and perfusion defects are normally not as black as these dark rim artifacts. So to deal with this problem, there are several ways of increasing spatial resolution. And as I said before, you can use KT techniques to do this, and you can acquire nice images with KT factor of 10, in-plane resolution of 0.3, acquisition time is 120 seconds. You get nice images. You can even speed up with 8-time undersampling with a 1.1 in-plane resolution, acquisition window of 19, and still you have really nice images for perfusion imaging. You can do perfusion imaging with adenosine and eubutymin, and diagnostic accuracy is the same. So the stressor you use is the one you want, and perfusion is as good in both, as you can see in this example with this patient. You can do eubutymin stress wall motion, as you see in the top row. On the left is the rest, then the 20 microgram, and the maximum stress. And you see it's actually difficult to see the wall motion abnormality in this patient, but when you add perfusion imaging to this, you can clearly see on B that there is a perfusion defect in the inferior or infralateral wall, and it depicts the coronary status. There is no scar in this patient, and you see on the bottom the terrible coronary angiogram of this patient. So it can help you to find the patient you have to treat, actually. So I talked always about 2D imaging. There are different ways of overcoming or coming closer to the nuclear methods, is to do a 3D perfusion. So that's what you did before. You had one pre-part and then acquired every slice. It is possible to acquire everything in one acquisition. It takes a 3D volume with only one pre-pulse. This is a nice thing. And we developed this, so we have you need to accelerate your imaging very, very high to 10 times. This is a net acceleration of 8. Spatial resolution stays low by 2.2, so still below 3. Acquisition window is around 200, but you get the whole coverage of the heart. As you have this, you can reformat this like CT images or whatever, and you can show your patient nicely where the perfusion defect is, and can use this for some quantification. This is a disk summation method where you can account for the part of ischemia. As we learned from the nuclears that ischemia is not good, and if you have more than 10% of ischemia, your prognosis is bad. So we, for example, did the study where we sent patients to before cath to MRI. We quantified ischemic burden, and then we measured them after. And we could see that their ischemia reduction after PCI is around 80%. We always see this Courage trial where they say PCI is not good for the patient because they don't live longer. I think we need to have a real method to find those patients who need PCI, which have to be treated, and with this invasive, and the others who need medication. So how good is perfusion? Actually, this is a meta-analysis of Nandala from 2007, and perfusion imaging has very high diagnostic accuracy. It's 91% sensitivity, and specificity is 81%. So it's really, really high. I always get this question, which scanner do I have to buy to do these things? Is it 1.5 or 3 Tesla? I have to say that when you look at the studies, there is a trend to 3 Tesla perfusion is better, but you get worse cine images, and late enhancement doesn't matter. So I would say 1.5 is sufficient enough for this, but there are some studies by Plein and by Cheng where compared normal and high resolution, and there was a trend to higher diagnostic accuracy with 3 Tesla. And this is an example of a study of Sven Plein with 1.5. He acquired 4 slides. You see in the upper row, you see the perfusion defect. You find the patient. It's quite nice. And in the bottom, you have the 3 Tesla. You see the image quality is nicer, but you still depict the perfusion defect in the same way. So we always have to compare, because we are the youngest of all, so we have to compare with the big ones. And there is a study, there are many limitations, obviously, in this study, about 700 patients where they compared SPECT and PET. And you see there's a clear advantage of CMR above nuclear medicine. And the authors conclude that CMR should be used more frequent in the diagnostic pathway of patients with coronary artery disease. There's another MR Impact 2 study where they compared also CMR and SPECT. This is a multi-vendor, multi-center study. And you see, it doesn't matter what kind of population you look at, CMR outperforms performs SPECT. This is in the total group. This is in multivessel disease. This is in men and women also. So there's always an advantage of CMR against this method. We saw this meta-analysis. It's quite nice. It shows also the diagnostic accuracy of all these three methods. And the authors nicely conclude that CMR may provide an alternative without radiation at a similar diagnostic accuracy of PET. So we have to consider this. The short, we have to know that we always get the question, because most of the studies were compared to coronary stenosis by quantitative assessment. And the gold standard now, also by the guidelines, is the FFR. And also against FFR, even the diagnostic accuracy of CMR perfusion increases, as in this nice study by Locke published 2012. See the area under curve is 0.2. Or we compared the 3D perfusion against FFR, and sensitivity and specificity was extremely high. So CMR compares very well with FFR, and this is a good thing. So now we have the diagnosis, now we switch fast to the prognosis. There's an incremental value of using MRI over cardiac risk factors to stratify patients. And you see, what are the predictors? So this is known coronary artery disease. It's many risk factors, but if you add inducible perfusion defects, this helps you. And this is where you see this Kaplan-Meier curve, where you see, but if you have a normal debridement stress or normal perfusion, your prognosis looks quite good, and if it's abnormal, it gets bad. And if you see this, it means you have an overall warranty of stress perfusion. If it's negative, you can say the patient has to come back in 2 years. This is quite good. But there's a difference in gender. So you can see from this, if you have a patient, a man and a woman, if they split after 2 years. So men have to come every 2 years, and women have to come every 4 years. That's what the author concluded from this study. There is also a complementary value of perfusion and late enhancement. If you add this together, you get additional information what will happen with the patient in the near future. There is hybrid imaging. This is a big topic. This is also from nuclear, where you have CT and SPECT together with around 10 millisievert. But you can do this 3D perfusion, combine this with a CT scan, and you get the same images at a more or less 1 millisievert. If you want to have this, it's good. Maybe some cardiologists want to have this to know what is. So this is the last topic. I will be ready in 1 minute. There was this microvascular disease. So what is this actually? Microvascular disease is an abnormal microvascular resistance, and it's clinically evident. It causes impaired myocardial perfusion and myocardial ischemia. And the important thing is that you cannot find anything in the coronary arteries. This is a more or less definition. Crea et al. Has a nice review on this, and he classifies microvascular disease in actually 4 types. One with absent any disease, they have this chest pain, or in patients with myocardial disease, hypertrophic, dilated, Fabry, they have sometimes this too. In obstructive disease, it means when we do something during the acute coronary syndrome, you have an microvascular dysfunction in the distal part, or iatrogenic, when we do something with the stent and the thrombus goes in the distal part. This does microvascular disease. It's around 10 to 20 patients with typical angina, have normal coronaries. These are mainly women. Generally, prognosis is benign. And this is the worst about this, it's terrible to treat these patients. These patients have frequent rehospitalization because of this angina. They get repeat cath, and quality of life is reduced. So this is my last slide. So this is an example of a patient I had this week, actually. She's 63 years old, patient with typical chest pain. She suffers really. She's not able to go to any shopping and everything, and also saw the psychiatrist already because of that. And she has a clear perfusion defect in the subendocardium. Rest perfusion is normal. We took her to the cath lab. The coronaries are normal, so we have to treat this patient, and she suffers really. So this is a really bad thing. But from MRI, we can at least say that this is not a psychological issue. There is perfusion, so we can tell her this at least. There was a nice study, 2002, in New England by Panting et al., where they saw that there is a clear perfusion defect in the subendocardium, and the epicardium looks normal. So I want to conclude. The major advantage of MRI stress testing is that it's now a robust method with a class 1 indication. We have highest diagnostic accuracy against other modalities. We have strong prognostic data. For men, it's 2 years. For women, it's 4 years. It enables now also hybrid imaging with CT. and it can give you further information about microvascular disease in these patients. I have to acknowledge our team in Zurich. We do all our research together with the ETH and the University Hospital Zurich, and I want to thank you for the attention.